Hi, everybody. Give everyone a little bit of time to connect to sound. And yeah, we welcome you to turn your videos on if you're able. Hi, Emily. And if you're not able to turn your video on, that's okay too. We know you're there. We know it's in the evening and there's often other things going on that you need to attend to, but we're so thrilled that you joined us tonight to hear alum Mika Milliren. I just want to say your other last name, sorry, from when I knew you as a student, but we're so thrilled to have you join us today. Emma is going to be doing a more formal introduction of our speaker, but I just wanted to welcome everybody to this afternoon or evening, whatever time it is. And yeah, seriously, Emily, I think you do get the award for being at everyone. So super happy to see you, even on, not in Ithaca right now. So actually, I don't know where you are, but I don't think you're in Ithaca. No, okay.
I'm in New York City.
Oh, nice. Wonderful. Okay, so some of you, like Emily, have been here to a number of these sessions and you've heard me say the introduction before, but I also know we have some newcomers, and it's just always my pleasure to give a little bit of the history of the series and why and how this came about, and to honor the co-founders of the series. So this series came about during COVID as one of the sort of the impetus was to find new and different ways for us to connect and build and reconnect our community in times that we were apart and really challenged, and to leverage some of our technology. And just that Zoom became more normal, and we wouldn't have ever thought about doing this, prior to the pandemic, to do something in a Zoom format, but it makes our community a lot more connected and gives us the ability to hear from, see, learn from, and with our alums who are all over the country, and some of them international, connecting them with each other, connecting them with our current students and our faculty. So, Julia and Emma, who are on either side of me on my screen, wherever they are for you, are fantastic, fabulous, visionary, now seniors. They were in their junior year when they had this idea about wanting to learn more about innovative and advanced practice and topics that aren't really covered in as much depth in the curriculum, and brought that idea to Jenna. Dr. Jenna Heffron, and we're just thinking, like, how can we do this and how can we bring more info to our students? So then they brought that to me, which merged really well with some of my vision and goals around connecting our alumni community. And as an alum myself, I know how important our alumni engagement is for so many reasons, and how our current students benefit from it, and from, again, how our alums benefit from being more connected to each other as well. So that sort of mix and mingle of ideas birthed this series, and now we are in our third semester. I've lost count of how many speakers we've had. We must be, I don't even know, close to 30 or so alums who have participated, and hundreds of different students who have sort of cycled through, and it's been fantastic. The topics have ranged. They've been, I think, more diverse than what we could have imagined. And the outpouring of support from alums has been, really just fantastic. So without further ado, I do want to turn it over to Emma, who's going to introduce Mika, and then she'll get on to the topic, which is, I know what you really came for. You didn't come to hear me talk, but again, honoring the co-creators of this series, and thanking our alums, past, present, Mika, and future ones lined up, who are going to be speaking. And for all of you current students who are on the call, know that we hope and expect you to be the ones presenting in upcoming years, and we can't wait to hear what you're going to be doing in your practice. So, Emma, I turn it over to you. Thank you.
Thanks so much for that, Julie. Thank you all so much for being here. We're so excited to have you. I'll start us off with some access info and then move into a little bit about Mika. But for closed captioning and the live transcript, if you click on CC live transcript at the bottom of your Zoom window next to reactions, you'll get two options. The first one is show subtitle, and that will make captioning appear at the bottom of your screen. And to turn off closed captions, just click on CC live transcript again, and then the hide subtitle option. The second option is view full transcript, and that will make the live transcript appear on the side of your Zoom window. And if you want to view the full transcript and the chat feature at the same time, just go to the top of the live transcript window, click on the downward facing caret, aka Karen, and then click pop out, and then you can move the live transcript anywhere on your screen. For the chat feature, that's at the bottom of the Zoom window next to the participants button, and similar to the live transcript, if you click on the chat button and then the caret at the top of the window, you can pop that out and move it anywhere on your screen. You're welcome to use the chat feature throughout the presentation. During the question and answer period, you can put your questions in the chat, you can unmute yourself, you can come off video, however it feels most comfortable for you to engage in the technology. The session is going to be recorded, and we'll also post an edited full transcript where we'll post it to the virtual OT site on Canvas for current students, faculty, and staff. If you are not a current student, faculty, or staff member and you want a recording, just let us know and we will find a way to get that to you. But tonight is our fourth speaker series event of this semester, and we have the pleasure of hearing from Mika Milliren. Mika is an occupational therapist at Encompass Rehab in Murrells Inlet, just outside of Myrtle Beach in South Carolina. She works on an inpatient rehab unit where she has a caseload of 6 patients, all who need to be seen by therapy for about 3 hours a day. A minimum of 30 minutes a day is usually spent in a group. She's worked on an inpatient rehab unit for 7 years, with 3.5 of those being at the current setting. She's currently working on her clinical doctorate as well at NYU, with a focus on educating fieldwork students, group work, and working on interdisciplinary teams. And when she's not working, she enjoys doing martial arts, specifically Taekwondo, aerial hoop or pole, and hanging out with her husband and 10-month-old daughter. So thank you again so much, Mika, for being here, and I will turn it over to you to get it started.
Thanks. You make me sound a lot more doable than I actually am. So I'm here to talk about group work, which a lot of therapists, I can't speak for when I was a student, actually I can. I hated group work. I hated it so much. I hated the idea of putting anything in the hands of other people. And then I entered the real world and I was like, oh, actually, I love group work. Please, let's bring it back. And I fell into doing group therapy at inpatient rehab units. So functional groups can really be important in a variety of different occupational therapy settings. These groups can create a supportive and social environment for therapy to take place. It's where individuals with similar needs or even different needs can gather to accomplish similar goals, assist each other, and promote socialization during very challenging times. I have yet to be in a setting where patients are in like a really positive scenario, and that's why they ended up in rehab. Most of the time, it's the last place they want to be. So groups in different settings can promote physical health, mental health, and improve quality of life. So I enjoy running these groups because I feel that they help multiple people all at the same time. So like Emma said, my inpatient rehab unit, I'm responsible for 6 patients, and they all have to be seen for 90 minutes a day. So how do you see 6 people for at least 90 minutes a day? You can't. So usually I'm responsible for seeing them from like 60 to 90 minutes. The only way I can do that is by running one 3 to 4 person group a day. So that's a lot because I see people who have all different backgrounds and diagnosis, and then I have to put them all in one group and like, now what? So I kind of fell into doing group therapy. My first job, I was a per diem therapist with a hospital system. So I did acute care, I did outpatient, I did rehab. And when I was doing a medical coverage on the rehab unit, I was required to run one Therax co-treat group with PT. And it was so boring. If you've ever had to stand there and be like, okay, raise your arms up and down, we're going to do it 10 times, is the most, I don't know why therapists do it. We all do it. If you work in geriatrics, you do it at some point. It is so boring. And it's not functional. There is nothing about Therax that is functional. I've done a lot of research on it. It's not functional. It's all preparatory activities. So I needed to make a change. I had to. I started bringing in my speakers. I got rid of all the weights and I started just changing it up. So I went from doing one group a day on that unit to doing 4 groups a day. I was basically running all of them. I kind of just stopped treating patients and I was just running all the groups, which to be fair was a lot more fun, gonna be honest. And then I transitioned to outpatient and I started to just do other work. And when I moved down here and I started working on rehab, I kind of got back into group work again. But once again, all of the therapists around me were doing TheraX, whether they were PT or OT. The PTs were doing lower body exercises and the OTs were doing upper body exercises. And it was so boring. So my first major group that I ever ran down here was a fall, like a how to fall group. And I actually had my husband come in, who's a professional martial artist, and run it for me. And he literally fell down for like 30 minutes, showing all the safest ways to fall. And then I would speak about what's the safest way to get up? How could we prevent this fall? And I had like 13 patients. I had 6 therapists in there and we had a blast. So from there, I just took it and I ran with it. And now I run several different groups a week, always with my patients. Sometimes I get buy-in from other therapists and they'll join me, but most of the time it's just me and my patients and we're doing something, as my supervisor would call it, crazy. So the biggest challenge is really like buy-in from other therapists. I don't know if any of you have been to an inpatient rehab unit, but it's usually like a bunch of rooms, a gym. We're fortunate enough to have a dining room. We have 2 day rooms that are like really big window carpeted rooms. And I usually find an empty one. I throw my patients in there with some music and we kind of stay out of everybody's way because my groups are very distracting. And a lot of the therapists are like, oh, there goes Mika. She's doing something crazy. Because I am. My groups usually consist of kickboxing, dancing, yoga/mindfulness training with a lot of breathing techniques. We'll do stretching groups to work on transfers. I have a drumming group. I did last OT month, the last year, I actually didn't. Has everybody seen Princess Diaries? Where they fill up the paint filled with balloons and then they throw darts at it to pop it. So I did that in my gym. And I had this huge canvas and it said like OT month on it. And they threw these darts and we popped paint balloons and there's still paint on my ceiling. So I'm not allowed to do that anymore. But it was great. And I had like, and unfortunately I had like 4 very old gentlemen and they just were thrilled to be throwing sharp things. So it was great. A lot of my patients are all different, like I said, ages and diagnosis. And a really good example is a group I had on Friday, actually. I had 3 older women from 3 different states. One was from like New Hampshire, one was from Philadelphia, and the other one was from like deep South Carolina. And if anybody's ever been to South Carolina, it's like really southern down here. And so having that eclectic group, and then one lady, she had a stroke. My other lady was there for really bad arthritis, and the other one was overcoming getting out of a coma. So I have 3 very unique diagnoses, 3 very different, unique individuals, and they all bonded over their love for Jason Momoa. Because that's just what I came up with. We were doing a exercise to lean forward to work on lower body dressing. So they all had to reach down and touch their toes to pick up a ball to throw it. And I said, we're building our abs like Jason Momoa. And you would have thought that the sky opened up because now I have these 3 ladies who are cackling and calling themselves cougars. And now they're best friends. And they're very upset because one of them went home yesterday. And they're very upset that their friend is gone. But that's one of the reasons I love running groups, because these people who would never know each other outside of this setting, wouldn't look twice at each other when they pass each other's street, are now stuck being the support system. I've been doing groups. We were even doing groups through COVID, which was really challenging because we were doing it 6 feet apart with masks. And it was so hard to coordinate. And yet these people were the only ones they were seeing the whole time because we weren't allowed to have visitors. So now you're stuck in a hospital for 2 weeks and the only interaction you're having is with your therapist and these strangers. So I looked at them all and I said, you have 2 options. You can either be a solo act or you can make a friend. And they made friends. And unfortunately, now they can go visit each other because our restrictions have lifted a little bit. And I have a sorority happening in one of my rooms right now because her husband keeps bringing her food and everyone keeps ending up in there. But that's one of the reasons I love running groups. So if I bring it back to how I like what I learned at IC to prepare me for groups, I took this crazy course called Individual and Group Work. And back then it was taught by this professor named Dr. Amy Gurney. And yes, we only referred to her as Amy Gurney if anybody's ever met her. And she inspired me with my approach to running groups. At the time, we were required to design and implement a group for a selected population using Cole's group protocol. Yes, I went back into my syllabus and I looked up exactly the protocol I had to use. And this protocol uses 7 steps to creating client-centered group: introduction, activity, sharing, processing, generalizing, application, and summary. At the time, I was chosen to do kindergartners, and it just really made me value the group process across the lifespan. Because at the time I thought I was going to do peds. Never actually did peds, but at the time. And really group work lays the foundation of the OT career path. Like if you go back to the history, because yes, the history does matter. You don't realize it until you're working, but it does matter. And that's kind of where OT started. And then for some reason we left it behind. We became, at least in the geriatric population, very biomechanical, very medical model, and we lost sight of it. So because of my interest in bringing fun back into function, because yes, I actually say that, the model that this follows, plus the types of groups I run, just make it great. And also all of my groups, believe it or not, are evidence-based, thanks to my wonderful students that I've had over my career who do a lot of my research for me. Because that's what I use my students for. I don't make my students do in-services. They do research for me so I can back up all my groups, because my funding in inpatient rehab is all covered by Medicare guidelines, because it doesn't really matter the insurance they have, whether it's Blue Cross Blue Shield, United, Medicare, Medicaid, they all follow kind of the same guiding principle. So because my groups are all leisure-based or IADL-based, however you want to put it, it's not your traditional Therax. So I need my evidence to back me up in case I ever get audited. So I make sure that I have evidence. And in inpatient rehab, the rule of thumb is 50% of your treatment has to be individual. Only 50%, which sounds like a lot, but it's not. And then at my company, we're required 75% individual. So that's why I do one big group versus several little groups. And I love the groups I run, and my patients love the groups I run. And my nurses think I'm bananas because all of a sudden they'll hear the YMCA from like down the hall, because my speakers are very loud, but it's great. And when I have students, they're required to run a group. When we get new therapists on the unit, I'm always the first one like, oh, you've never run a group before? Go watch Mika's group. And I really think that running groups, if you ever have the opportunity to do it, take it and run, and make sure it's something you enjoy doing. My last student I had was from the MUSC program, the Medical University of South Carolina, and she had never run a group, and she was super nervous and she was a little introverted. So the last thing she was going to do was run a dance group, because you need to be very extroverted to do something like that. But she started running a fall prevention group that actually took off like wildfire. She created a whole fall prevention bingo. It's like Jeopardy meets bingo, and now my entire unit uses it. And it's great. She had like 4 different boards and 1 answer key. My patients love it. We work on fine motor control because they use poker chips to place it. We're also doing fall prevention and safety, which is really important on an inpatient rehab unit when you're trying to get patients home. So, and then my student before that created our what to expect and discharge group programs that are still in effect today. So all of our patients go through what to expect. All of our patients go through discharge groups. And then I run the stroke support group that meets once a week. So I've run hip groups, I've run amputation groups. I think if there's a diagnosis out there, you name it, I've run a group for it. I got my LSVT certification back in December, and I started using a lot of those techniques in my group sessions. And as long as you understand the patients in your group, because it's not like it is in school. You know, in school they tell you, this is the population you're working with, this is the age, and this is their diagnosis, go. Well, when I started working, it was like, okay, well, that person has this diagnosis and that person has this one. And you have to hold it all in your head and now make one group for all these people. So it was easier for me to just create a group and then do this crazy OT thing called modify. So everyone's doing the same activity, just a little bit differently. So if we're doing, you know, chair push-ups to work on transfers, I usually have them do it as a race, because who doesn't like competing? And the winner gets to go back to their room first at the end of the session. That's their prize. So they have to do like 10. Well, Jane has sternal precautions, so she can't push up. So maybe she doesn't participate in that exercise, and I give her something different to do. And Joe over there, he's got a bum shoulder from an old rotary cuff injury, because that's what he told me. And he can't do it either. He's got to modify it a little differently. And I just keep that information in my head and I just modify it. I don't really change what I want to do because it'll still impact them. They still need to work on it. But that's the beauty of OT. I can just adapt it. And that's kind of how I run my groups. And I wish I could tell you that I plan my groups out the day before, because that would be lovely. But if I know I'm running like a big group, like my big painting groups that I run, or if I'm doing something for the holidays, like Easter's coming up. Easter's a really big deal down here. So I have to prepare all that stuff in advance. So I know that next week, my supervisor already has told me she's bringing in Easter eggs and I've got all my dyeing stuff already. So that kind of stuff I set up beforehand. But because I run a group every day, I usually see who's in my group in the morning. And then I'm like, okay, this is who I have. These are their diagnoses. This is something they haven't done yet. We're going to do that. So I know I'm running a group tomorrow and they're going to do kickboxing because I did all the other groups this week. So that's the last one kind of on my list of groups to do. They've got to do kickboxing tomorrow. And yes, I do have, you know, those individual ones that you use for stress. They sit on your desk and you hit it. Got like a suction cup at the bottom. I have like 6 of those. And they sit in a circle and they look at me and they're like, what are we doing? I'm like, we're hitting things. We're going to hit things for 30 minutes. They're like, that sounds great. I said, yes, you could put your therapist on it, you could put your nurse on it, put the guy who didn't come to check the cable the other day on it. And so I had a lady the other day, she goes, this is for my old boss. And she just starts wailing on it, which was great. And that works, believe it or not, kickboxing. There's a lot of research on it, especially if anybody's really into Parkinson's, like the diagnosis. There is a program, at least in our area, called Rock Steady Boxing. And that's where I got the idea from. I did a lot of research into Rock Steady Boxing. And that's where I got the kickboxing idea from. So look into it. It's a great program. I take yoga balls and drumsticks and I set them on chairs. I don't know if anybody saw that video like a year and a half ago of these seniors in a senior living center, and they were all like banging on these yoga balls and baskets. I actually do that. I have my music and I take it and they sit in a circle in their wheelchairs and their yoga balls on chairs and they just drum away. It's really loud though. I have to wait until like 11 o'clock in the morning to do it. Yeah, I think that if you have a chance to run a group, you should definitely do it because it's hard. It's probably the hardest type of therapy because it's not one-on-one. You're managing multiple people at the same time and somebody's always got to go to the bathroom, you know, so getting them all in one place at the same time to do one activity is a challenge, but it's so worth it. I've had them do the craziest things. They let me do it and they have a good time, and they're still talking about it. Those 3 women I were telling you about earlier, I was walking out the other day and one of them was sitting outside the other one's room talking about one of our male OTs because they have a crush on him. And I went up to them and I said, "What are you doing?" They said, "We're talking." I'm like, "We're not in therapy anymore. You can go rest. You can go talk to your families." They're like, "Yeah, we'll go. We'll get back there." I'm like, "Okay. See you later." So it's really nice to see it. And not all my groups are perfect. I've definitely run like a dancing group and people are sitting there like this. But they still talk about it later. Like even I've had the most curmudgeon-y old man participate doing the YMCA and he sits there like this. And then the group ends and he goes, "That was really interesting." I went, "Thank you." So it definitely makes a difference. It improves their quality of life on the unit, which for me is the most important part. And then it makes my day a lot more interesting and fun, which is selfish. And then a lot of them, I just see a ton of change. They get more social. They see somebody who kind of looks like them and is acting like them, and they don't feel as alone anymore. You know, I'll do a discharge group and we'll talk about all the resources they can use to get home. And it just creates this discussion of things that I didn't think of, that they might not have thought of, and they end up going home much more successful. So yeah, I think that's everything.
That was awesome. Thank you so much, Mika. So we'll sort of transition now into like the Q&A period. So like I said before, if you have any questions, you can feel free to unmute yourself, put it in the chat, all that good stuff. So I'll give a second to see if anybody has any questions.
I have a question. I can start us off here. So Mika, thank you for that presentation and kind of glimpse into your kind of daily routine with group work and managing that with individual one-on-one sessions as well. I heard you at one point talk about a specific group that I'd love to hear more about. You mentioned a stroke support group and kind of you're taking the lead and running that. And I'm curious, hi Merritt. Curious if you can tell us a little bit more about like the details of it, like how many sessions is the group, what types of like, what are the topics of the different sessions, kind of giving us a flavor in that way.
I would love to. My hospital, it's a new unit, but it's not a new unit. So we're currently going through stroke certification process to get stroke certified so we can get more resources and just be known as like the place to go. Because I actually live in something called the stroke belt. I don't know if anybody's ever heard of it, but in this area, there's like this little line and it's just got the most condensed population of stroke victims in the country. So a lot of the hospitals around here try to get stroke certified because there's a lot of people, we have really poor health literacy down here in South Carolina. So what my company ended up doing, and I ended up representing the occupational therapy side of it, is each discipline goes over why they're important to stroke rehab. So on Mondays, it's nursing and case management. Tuesdays is PT, Wednesdays is OT, and Thursdays is speech therapy. So in my session, and it meets once a week. So if you get admitted today, you'll start your stroke education sessions, we call it, the following week. So on Monday, you'd start. So when it comes to me on Wednesdays, same time, same place, I have a PowerPoint presentation that I follow, and we talk about like, this is the stuff that impacts you in terms of occupational therapy, bathing, dressing, toileting, IADLs. We talk a lot about driving because it's the number one question around here. There is no public transportation and none of my patients can drive. So we talk about that. We talk about driving rehab because we do have a local CODA, believe it or not, who is a driving rehab specialist. So we're really fortunate. And then I talk about positioning with sleeping. I talk about positioning for the shoulder after subluxations or if they have a significant amount of tone. I talk about all the adaptive equipment that we can give them and where they can find it. And then I'm responsible for talking about all their discharge options, because I have some patients who are really strong and they go straight to outpatient neuro, which we also have a really good connection with. And then I have patients who can't go home at all. And so we talk about those options. So it's a really interesting, and a lot of hospitals I know that are certified will do some sort of stroke education. I really like the way we do it, because a couple of weeks ago I was running it and I had people of all different levels. We always make sure families involved, especially if my patients aren't totally cognitively aware. Their family has to be there. And a couple of weeks ago I had people of all different abilities. So I had to talk about things as broad as I could. And it was very interesting to see my patient who was moving a lot better than my other patient was, and how they were still able to see like, oh, well, this would really help you, or, oh, okay, well, this impacts you more than me, and that's okay. Because it's, unfortunately, once you have a stroke, you're more susceptible to having another one. So with our higher functioning strokes, I hate saying that, but those were a little more higher level. It's really important for them to know the full spectrum just in case it does happen again. So we do a lot more than you would think. It's not just about the arm anymore. It's about their ADLs. It's about their positioning for sleeping. Occupational therapy in my setting at my specific facility has really taken the lead on positioning for sleeping, mainly because we were having such a high case of subluxations. So that's why we add it into our stroke support group.
Does anyone else have any questions? Did that bring anything up for anyone? I know for myself, you mentioned earlier in the presentation, one of the most difficult parts is getting buy-in from other therapists. And you just talked a lot about how you sort of present what OT's role is in various settings and conditions. So I was just sort of wondering, like, how do you go about advocating for OT services and especially groups within your role? And do you have any like specific strategies?
It's a lot of it is confidence. A lot of therapists are very set in their ways. I don't know how many of you have been out on field work yet and have worked with therapists in different settings and seen like, well, this is the way I do it here, and this is the way it's always kind of been done here. And that's just kind of how it is. And that's how a lot of students are just trained. That's how a lot of new grads are introduced to facilities. It's very, this is how it's done here, and this is how everybody does it. And that's how I got introduced to groups. You know, I thought it was just go in, show them some exercises, that'll be your group. And it was really like my confidence level, and honestly, my total lack of interest in the group that made me want to change it. And so I'm still working on buy-in. I've been at my facility for 4 years. I'm the senior OT there, and I'm still fighting for therapists to do it a little differently. Like, let's do something different. So I would really encourage everybody to just do your research, do something that makes you feel good and that you're confident in doing. And hopefully you get buy-in, because sometimes it's a little addicting. Like, hey, it's not that hard. Because I do have a couple of people who do pick up the kickboxing stuff that I have. I have an air hockey table, so a couple of people will do like air hockey. I have cornhole, so people will do like cornhole. We all do it a little differently, but we're working on it. It's a work in progress.
And Elena just asked in the chat, is this what you thought you wanted to do in regards to working as an occupational therapist, or how did you discover this type of work?
I thought I wanted to be a certified hand therapist. And then I decided that was really boring. Because I don't know if you've noticed something about me. I have a ton of energy, and I actually have 1,000 hours in hands. I was getting really close to going through my CHT training, and it was just so boring. And I kept finding excuses not to see hand patients. And I really just wanted to get back to inpatient rehab. And once I got back into inpatient rehab and I was doing more groups, that's just kind of how it ended up being. And I kind of, honestly, I fell face first into it and I haven't looked back. And I've done a lot of different things at my job. So I took high school students, local high school students who were really interested in going into the health sciences, and they came in on Saturdays and Sundays back when I worked every weekend, which that was an experience. And they were running leisure groups because we don't have rec therapists at my facility. So I was basically using high school students to be rec therapists on the weekends. And when I lost that ability because I no longer worked weekends, because selfishly, my husband's a teacher and I couldn't see him. So I went to Monday through Friday and I just decided to take on the role during the week. And I set it up on the weekends as much as I can. Like I'm working this Saturday and I have a paint group already set up.
I have a question. So ironically enough, I just led my first group session today in field work. It was with, I'm in a pediatric setting though, but I've realized things might not go the way you intended something to go. So I was just wondering, like, what are suggestions you have and like thinking on the spot if something might not go away for a group, or like problem solving within, or like how to prepare kind of for something not like a plan like Z or something.
I'm honestly, with pediatrics, it's so challenging because you're trying to get something very specific out of them. In inpatient rehab, thankfully, it's a little bit easier because you're basically just trying to strengthen them. But what I do is I just plan a very, like, all my group sessions are basically an hour that I fit into a 30-minute time span. So that way, if something goes wrong or somebody's not interested in something, I can quickly change on the spot. So for example, my dancing group is a very hit or miss. And all of my songs are purposely 3 to 4 minutes long. So if I see somebody getting tired or their interest waning, I can just be like, okay, we're going to do this one more time and then we're going to wrap it up. And then I can just quickly move on. And it feels like it's just how the group is supposed to run. And that's kind of how all my groups are. I have it set up so they're very, very long. And then I just shrink it to whatever the group needs. And that's how I kind of change it. So my drumming group is the same thing. I have very long songs with specific exercises that I just kind of cut and peel. And sometimes it works great. And I can do whatever it is I need to do. And after 30 minutes, I'm like, well, then just end it there. And then sometimes I make it through an entire hour session in like 25 minutes. And I'm like, okay, and for the last 5 minutes, we're going to work on breathing. So I promise you it gets easier over time.
Okay, thanks.
I had a quick question. Thank you, Mika. This has been great. And I missed a few parts of it. I have a little distraction here, so you can see. But I love your phrase that you put the fun in function, and that you it sounds to me like you're using a lot of play and play for adults, which I know sometimes people do resist. I teach our play and leisure class now, and I'm curious if you feel like some of the pediatric stuff you did and some of the prep you did in pediatrics sort of, because I know you thought at one point you wanted to go into peds, and sort of prepared you or helped you to kind of embrace that side of your OT personality.
I think the reason I wanted to work with kids back when I was in school is because I secretly am a child. Like, you can't tell because I'm in my room and the wall behind me is blank, but I have like Minnie Mouse ears up all over my apartment. I'm a huge Disney person. I have a ton of energy all of the time. So that's always been the joke with me and the other therapists I worked with, is that I was like the child. So a lot of that is I never gave up the idea of play. And I never understood why adults don't play, because like my parents play and my aunts and uncles play. So why weren't we doing that in rehab? Because IADLs and leisure activities are a really important part of quality of life. It's not enough that, I can go to the bathroom by myself. Don't get me wrong, super important. But now that we did that, a lot of them will just end up sitting around watching TV. And I don't know about anybody else. I can only watch TV for so long. I mean, I did watch an entire season of Bridgerton in one sitting, but then I needed to do something else. So that's kind of where it came from. A lot of it has to do with how much I saw it in pediatrics and none of it in adult therapy. And then when I made the decision to be an adult therapist, it just was very natural to bring it with me. And you won't believe the amount of my patients who are like, I don't play games. And I'm like, well, we're going to start. Like some of them have never played with a deck of cards. I'll take out bananagrams. It's a really popular thing I do with my individuals one-on-one who have had a stroke or Parkinson's to work on fine motor control and some cognition. And they've never played Scrabble, let alone bananagrams. They've never, played Jenga before. And they've never played like Connect Four. And then you're teaching all these basically games. So it's really interesting to bring that idea back to them. And then I went to the dollar store once and I bought like all these decks of cards and I just hand them out to patients. I'm like, take this back with you. They're like, what's it for? I'm like, you're going to play solitaire with it, but I have an iPad. I don't care. Put your iPad away. So it kind of is like working with peds, I guess.
I love that. I love that focus on play. And I think that, it is culturally, we have forgotten that. And some of our dependence on screens and some of our, yet the research is super strong that play is one of the best ways to learn new things, right? And when you're in rehab, you've got to learn a lot of new things. So really, I think a lot about how much play can be valuable across the lifespan. And
I will say, when I was in your, I don't know if you remember, but I was in your research.
I do.
Thesis, right before he was born, because that's how old I am.
Yep.
I found an article that I wanted to use for our paper and I didn't. And it actually, I'm a big fan of Mary Poppins, huge. And it's a whole article about the importance that she has when she talks about I love to laugh and a spoonful of sugar, and how they took that and they matched it with occupational therapy. There was a whole journal article about it. And that was my basis for my doctorate. Because my doctorate is all about groups and working with fieldwork students and leadership, but it all ties back to this idea that we need to bring, very cliche, the fun back into function. So.
Great. Well, I love hearing about and all the things you've done and seeing you do this. This is great. You were in one of my very first groups as a professor. So it's really lovely to see you here. Thank you.
I love hearing that all too, Mika. That's so fun. Hannah and Jill asked in the chat, would you say this is a taxing job on your body?
If we're talking about inpatient rehab, I would say 1,000% yes. I do dependent transfers on the daily, which if anybody has anybody gone over GG scoring in school? Okay. They basically got rid of FIMS and now we only do GG scoring, but basically my patients can be anywhere from needing more than 50% assistance to move to 100% assistance to move, just to get into a wheelchair. So it's a very taxing job. My day starts at 7 a.m. and it's I call it a full throttle push all the way till noon when I get my first break. And even then I'm making sure all my patients are setting up. I have to do my documentation. I go back on the floor at 1. And believe it or not, I did that all while I was 9 months pregnant. I actually worked myself into gestational hypertension and I had to get kicked off because my blood pressure was way too high. Because I did a full blown catch. My patient was walking and they stumbled and they buckled and I just caught them. My supervisor looked at me and she went, "You're done." So it's a taxing job, but it's super rewarding if you're into something like that. And group work isn't as taxing, but I do have to get everything together and all my patients there. Then once they're kind of all together, I can relax a little bit and then but my energy level knows no bounds. I'm constantly like jumping up and down. And I guess that goes back to like pediatrics. I'm constantly like, if I'm the biggest fool here, they're going to do more. So, yeah.
And that kind of goes back to why you didn't end up loving hand therapy. But we have a question from Elena of why did you think you wanted to be a hand therapist before you realized you didn't like it?
So my dad is deaf. So I've always had like a weird fascination with hands because I grew up doing American Sign Language. And then when I was a fieldwork student, all of my fieldwork supervisors were super influential on me. And I did a hand therapy rotation. I was like, this is great. But then I realized I hate crafting. Splinting is crafting. Hands down, it is 100% crafting. I still do splinting in inpatient rehab using a hydroculator where I keep the hot packs because we don't actually have a splint cart. So I'm really happy that I did it at some point in my life, and I respect hand therapists so much. It just wasn't for me. I like the go aspect of my job versus when I did outpatient. You know, if your patient cancels, you have 30 minutes where you're sitting there doing nothing. And it was also a lot of work. It's a lot of work that I didn't want to do. I'll be honest, but I'm happy I did it. And I met some great people doing it.
I'll ask a question, Mika. Super interesting. I love everything you're sharing, and I remember you as a student and your energy knowing no bounds for sure. So I can totally vouch for that, and just being so fun. And I can see why a job where you're like literally bouncing around, suits you so well. So I'm glad that you have found this great fit. So I'm just curious if you could maybe tell us a story of either your like absolute favorite moment, like the group that went the best, or take it in another direction, like what flopped, or both. I don't care. But like what really stands out for you as one of your best memories for whatever reason in your group work experience?
Oh my gosh. I can't tell you, I run at least 6 groups a week. That's a really hard. I think the balloon one is definitely one of the ones. I think I have groups that I like doing better than others, and it's all about the personalities I have in the group. I went through a phase where I was making stress balls in groups. I had flour. I got like a 16 cc gauge, like syringe from one of the nurses, and we were like pumping flour into stress balls, like balloons that I had, and that was a lot of fun. At the holiday season, I'll make dreidels out of marshmallows and Hershey Kisses, and I have little frosting and like pretzels. We make little dreidels, and we'll make Christmas cards, and I'll make Valentine's Day cards. At Halloween, we did pumpkin painting one year. That was terrible because I had to get rid of all those pumpkins. And I'm on a 4th floor. So it's not like I can just like walk outside and like throw them somewhere. I had to like drag them down 4 flights of stairs. But I think my best group probably was I ran a Halloween dance group, and it's just like me decked out in like I have like a Mickey shirt with like skeleton bones on it. And I had like this huge top hat I threw on just for the group. And I played Michael Jackson's Thriller. I played the Monster Mash. And we just boogied down to Halloween music. And it was one of my first times doing it at my current setting. And I had like people just popping in going, what is happening? I had like 5 people in the group who were all just doing this made up Thriller dance that I had made up the night before. So that was probably one of my best ones, next to one my husband and I ran together, which was great. I think the only reason my groups flop is, honestly, I haven't had a group flop in a while. And again, it has to do with personalities. Sometimes I just put the wrong personalities together and it's just a very like silent group. But they happen. And I have had patients tell me that they don't want to do groups. Like my Hanukkah group isn't exactly very won over because it's the South. So I have to deal with like a lot of prejudice So I have to be very careful. A lot of times I have to switch it from like a dreidel group to a snowman group because they are just not as accepting as I wish they were. So that's been challenging, but we just take it as it is. And the snowman always works out well. And then making sure they don't eat it because diabetes is really big down here. So
I don't know, Mika, some of those things sound like crafts to me. You said you don't like crafts.
I really don't like crafts. My old, not my current supervisor, but my old supervisor was a really old school like crafting OT. So she really like pushed for me. She's like, it's the holidays. And I was like, okay, just get it for me. Splinting is a whole nother level, as you know. Like, I can tell people how to set it up. I don't actually make anything though. And the painting group actually stemmed from this. We had a professional artist and they made like this huge deal out of it. They videotaped her whole rehab, posted on the internet. It was crazy. And I had her for like a week while her primary therapist was out, and we did painting together to work on bilateral coordination. And I had her doing stuff with her affected side. And a couple of my other patients were like, oh, you guys have paint? I want to paint. And that's kind of where my painting group came from. Not the Princess Diary style one. That was a crazy idea I had. Like, it was like a fever dream. I woke up one night and I was like, I'm going to do this thing.
So great. Thank you. Jenna's new visitor or new puppy just came on camera. We haven't seen your pup yet.
Yeah, that's Ren.
Cute.
Thank you. Just scratched my neck though.
If there are any questions coming up for anyone else. If not, I have one. You earlier mentioned like how one of your favorite things that comes out of groups is the social interaction that your clients get. And so knowing that you work in a more kind of medical model and like physically based setting, how do you integrate those social aspects and those psychosocial aspects into your treatment and into your groups?
One of the big ways that I personally do it is I don't do point of service documentation, which is really popular in today's day and age. Everybody walks around, at least at my facility, with laptops. So what happens is, especially when they're doing group work, is you'll see therapists like typing away, and I purposely will set mine aside. I'll ask the group, like, what kind of music do we like to listen to? If I'm not doing like a dancing or drumming group, I'll put that on. And I usually talk to them like, okay, where's everybody from? What therapies have we had today? How's everybody doing? And that kind of just starts a chain of conversation. And then I try to carry it over because I see the same people day in and day out. They see each other day in and day out. So those 3 women that I were talking about who did the Jason Momoa obsessed people, I purposely put them in a group again on Monday morning. And they're like, I was like, okay, who'd you have over the weekend? What did I miss while I was gone? And they all told me that the male OT was back and he looked good. And I was like, oh God. But it was really great just to see them. They're like, oh, we saw each other on Saturday. And, you know, so-and-so's husband was here. And hey, did your kid come in? And it just makes it just really supportive, and it gives them something to look forward to. One of the women who was in the group, like I said, got really upset because somebody went home on Wednesday and she doesn't go home till tomorrow. And I said, I'm not going to see you tomorrow. She goes, will I see so-and-so? And I said, I can make it happen. You really want to see them? She's like, okay, can I see them before I go? And I was like, sure, see them before you go. And it just creates it makes them look forward to going to therapy, because nobody wants to go to therapy. Like, no one wants to see my face at 7 o'clock in the morning. It's my joke. Every time I walk into the room, it's usually still dark. I knock on the door. I'm like, good morning. It's Mika from occupational therapy. I know it's early. So it does help. It really brings up that whole idea that we're putting the client first. You know, I'm not grouping them together. I mean, I group them together because I have to, but I try not to make it feel like you're lumped together because it's the only way it'll fit on my schedule. I'm putting you together. We're going to do this thing together. and we're going to have a good time. Because if I have a boring group, if I have a boring session, it's like having a bad individual session. It feels like a waste of time. And in inpatient rehab, I have my patients for a max of like, the average stay on an inpatient rehab unit is 14 days. I have 14 days to get these people ready to go home. I can't waste time. So even though we joke around that you're doing a dancing group, you're doing a kickboxing group, like how does that help? I have all of my evidence that shows why it helps. They just don't realize that they did it.
I think we have time for one more question, two more questions. Yeah, like Julie said, the power of occupation, being kind of sneaky, but for a purpose.
And I'm hearing so much, therapeutic use of self and just what an integral part you are in the groups and the ability to bring people together, work on their goals, have them do hard things without knowing they're doing hard things, right? So that's huge, that therapeutic, back to the question around like psychosocial and how do you address some of that. And that's, I think, probably one of your biggest tools, Mika, and how much you bring to this and what your personality and your ability to rally the troops and get people going is just remarkable.
And I tell always, because I work with a lot of students, I take 2 to 3 students a year from the medical college, and I tell them all the time, like, it's going to sound silly because I know your professors told you, but all that theory stuff you went over, it comes back. All that stuff you learn about therapeutic use of self, and I know that's that's the answer. It's like, oh God, what's the answer? Therapeutic use of self. I remember I took the tests, I did the thing. And then when I went to NYU and I started really applying a lot of this knowledge from my doctorate, I went back to all my master's and undergrad level stuff. And I was like, oh, I did this already. It actually does work, actually does apply. So I tell a lot of my students, like, go back to those classes, go back to that way of thinking, because you lose it when you go on your clinicals, which is super unfortunate with the way that, at least with geriatric placements, you lose a lot of it. And I love being an adult therapist. I love working with adults. I have a fun, it is super stressful every single day because you are dealing with a lot, but my patients make it so much fun because I want to have fun. I play hide and seek. I was playing hide and seek with a 70-year-old. I hid cones around the kitchen and she's like, we were playing hot and cold. And by the end of it, we were discussing the importance of redoing her whole kitchen because she realized, like, oh, I can't reach down there anymore. I can't reach up there anymore. But she wouldn't have figured it out if we didn't try and go and do it. And the same thing happens in my groups. A lot of them are like, I'm like, you can do this all in your room. You can do this all when you go home. I tell them, if you love kickboxing, go on YouTube. It's free. If you really liked this yoga session, it's free on YouTube, and I actually see my patients do it. I walk by their room and I'm very nosy and I look in and their commercials on TV and they're sitting there doing their stretches. And I stick my head in the room like the person I am. And I'm like, you're doing great. So I promise that what you're learning, even though it feels very repetitive, if you don't hold it, therapy can get very boring.
I think that is a great note to end on. Thank you so much, Mika, for all your words of wisdom and all the amazing work you're doing. I'm sure your clients can feel the fun and functional and are so lucky to have you. So thank you so much all for being here. And again, Mika, for sharing all of your work. This month, because it's OT month, we have more than one session. We have 3 sessions, so 2 more after this. Our next one is April 21st with Taryn Rosner on applied functional therapy, which is a unique interdisciplinary model. So we hope to see you all on the 21st. And thank you again so much, Mika, for your time. We so appreciate you. Yeah, have a great night, everybody.
Thank you so much.
So much.